So topic is history taking and general physical examination. Or in your competencies means the syllabus, the structured syllabus, which I have told repeatedly, but those who are relatively new may not know. You search out CBME 2024 on the internet, you will get your structured syllabus. So it is written, you will see PY12.9, PY, the competencies in physiology. Competencies means the topics are given as, they are named as competencies. The name competency, probably it means that the student is expected to be competent in this and this topic. So the topic PY12.9 is obtain history and perform general physical examination or general examination in a volunteer. Volunteer means in this case, in the first phase of your medical curriculum, you have to, you are learning on your, practically on your own colleagues, okay. You are learning clinical examination on your own colleagues, they are the volunteers. From the second phase onwards, or sometimes few classes in the first phase, you may have to visit the OPDs and wards, and one slot is allotted for that Saturday second half. Okay, early clinical exposure classes, yoga classes and all these are kept for Saturday second half. Mostly you don't have to visit actual, you don't have to visit the wards, or you don't have to work with the patients in the first phase of your curriculum. That is from the second phase onwards, after you take the university exams on anatomy, physiology and biochemistry. But general idea about obtaining history and general physical examination is included in your syllabus for the first phase, that is covered in the topics along with clinical physiology. So what does obtaining history means? Here in this case, obtaining history means knowing, trying to know about what the subject is, what the individual is trying to convey to us. He or she, the subject, will speak out, and by verbally communicating with him or her, as medical professionals, we also have to gather some information, and that will be this precedes clinical examination. Actually it goes along with clinical examination. You are, when you become actual experienced medical professionals, as you gain experience, the subject comes to you, you start clinically examining him, along with you verbally communicate with him or her, so that you have a preliminary idea of what you are going to do, what line you should be in, so that you can diagnose a medical condition and treat him or her accordingly. Now few things to remember, that few terms which we should be acquainted with. One is, whom do we call a subject and whom do we call a patient? Do you know this? So any individual who is coming for medical examination, we will call him or her a subject, and patient is, very strictly speaking, in whom actual some medical issue has been diagnosed. Now sometimes we will find as medical professionals, due to various reasons, people are even faking illness. Maybe people are faking illness so that to gain some undue advantage. So our duty as medical professionals will be just to, somebody may come for a medical examination, so medical advice. So we will conclude that there is no need for any intervention right now. So very strictly speaking, that person is not a patient, because nothing has been diagnosed, no medical issue is persisting. Okay. Even I am talking of faking illness, but even without that, people may come for some medical advice. That is within the rights of an individual, that let me go and seek some medical advice whether I need something or not. So if nothing is diagnosed, no medical issue is persisting, then we don't call that individual a patient. Okay. Another example is, say, a pregnant woman. Pregnancy itself is not a disease. It's not actually a disease. It is a physiological condition. It is perfectly a physiological condition. So, if pregnancy is not associated with any disease, like in pregnancy sometimes there is due to this pregnancy itself there are causes which lead to increase in blood pressure, increase in blood glucose and all. If some ailment is diagnosed along with pregnancy, diagnosis means to establish a medical issue, that is the meaning of the term diagnosis. Some medical issue till it is established, pregnancy is not a disease. So, better not to term like this, not to use the term a pregnant patient. Very that means just commonly we tell like this pregnant patient, but it should be called pregnant lady or a pregnant subject, not a pregnant patient. Okay, because pregnancy is not a disease. That is the difference between a subject and a patient. So, whom to call a subject, whom to call a patient, you will decide by this whether any medical issue has been established. Now, if obviously when somebody comes to us as medical professionals, if we find something obvious, then right from the start we can call him, right from the first interaction we can call him or her a patient. Like somebody is entering coughing vigorously to your chamber as a medical professional, he comes to the outpatients department, that individual, and you are seeing he or she is coughing vigorously. There are symptoms. Okay, we'll discuss the difference between symptom and sign. So, there are symptoms, there are you are finding something which relates to him or her as a patient, that there is some medical ailment or the other. So, you can call him or her a patient, but without any medical issue persisting or without any medical issue established, that is, you call that person a subject. And what is the difference between sign versus symptom? Anybody? So, symptom is any characteristic which the subject complains of. So, somebody comes to you, sir, I have fever, madam, I have suffering from headache for the past 3 days, I have having pain inside my belly, okay, which you medically you call the abdominal pain. I have got hurt and I am limping for the last 3 days, okay, or my ankle is paining, it got twisted. So, all these what will be any characteristic that will be spoken of, that will be complained, that will for which the individual has come to a medical professional is a symptom. It may be fever, it may be headache, it may be pain, anything. Now, what do you do if a subject complains of fever? What do we as medical professionals do? We try to we put an hand on the skin of the forehead or skin of the neck and try to elicit whether the subject, whatever he is complaining of, that fever, whether it is persisting. So, what we see actually, we try to elicit the temperature of the subject, that means body temperature. So, fever is the symptom, but the corresponding sign is body temperature. If the subject is complaining of pain, say in the upper part of the subject is showing this upper part of the, I am having a pain in the right side of the upper right part of my belly. So, you put a hand over there, slightly press the area, and you ask him or her, are you feeling more pain, or whatever pain you are speaking of, when I am putting my hand, is it paining more? The subject will probably say yes or no or something. So, that which is elicited is called tenderness. The area, we call it as this area, the subject has spoken of pain and we are examining this area, we have found the area to be tender. So, pain is the symptom, but tenderness is the sign. So, this is the very difference between symptom and sign. What the subject is complaining of or subject or patient is complaining of is a symptom. What the clinician or the medical professional is eliciting, that is sign. So before proceeding to clinical physiology examination, although we have had two topics have already been discussed, examination of the arterial pulse and recording of blood pressure, that is recording of blood pressure and arterial pulse at rest in a subject, that topic has been discussed. That is a part of actually measuring pulse or estimating pulse and blood pressure is a part of general physical examination as well as the systemic examination. Which system? Cardiovascular system examination. It is a part of that, but clinical examination actually starts from obtaining history from the subject and general physical examination. General physical examination, we have to do any we visit any subject who visits us, whether for some he knows or he has some complaint or not, he or she has come for some advice whether some medical intervention is needed or not, whatever we need to do general physical examination as medical professionals in all subjects. Anybody who is coming for medical advice, general physical examination is must. Obviously systemic examination in short we have to do, but we have to concentrate on systems according to our experience. Somebody is coughing of cough and cold, sneezing vigorously, then we are probably thinking of something in the respiratory system. Then we will concentrate on respiratory system, but we will also, in short, we have to cover very that means in very briefly the other systems also. Okay. So examination of the respiratory system, cardiovascular system, nervous system. Okay. But we have to concentrate according to the symptoms or the signs which we elicit, we have to concentrate on that system, but general physical examination is a must for every subject who is coming for, whom we are going to treat or whom we are at least who have come for medical advice. If nothing is needed, we may write, medical professional has the right to write, okay, this subject, this individual had come for medical advice, but at present we are finding, my finding is that, or my conclusion is that no medical intervention will be needed. Obviously as professionals we have the right to do that, but obtaining history, whatever the subject tries to communicate to us, to obtain history and gathering information and doing the general physical examination is mandatory before concluding anything. Okay. And in briefly the systemic examination also. So general physical examination is very important. So history taking or obtaining history starts with patient particulars. Patient particulars: name, age, the gender of the individual, address and occupation. These things are mandatory. Now if you work in a hospital setting, you are working at an institute probably especially in case of the outpatients, not specially, in case of the outpatients department or in the inpatients department where somebody is hospitalized. Somebody is hospitalized means, again, just from common sense, we may call him or her a patient. Somebody is hospitalized, obviously some medical issue is there, otherwise he or she would not be hospitalized. So you as a medical professional, anybody who are medical professional goes to visit a individual who is already hospitalized, say by some another medical professional. So it is taken for, that is obviously it is that due to some medical issue he or she has been hospitalized. So we can straight away, strictly speaking, we can straight away call him or her a patient. So we are visiting some patient or somebody has come to the outpatients department, we still don't know whether medical intervention will be needed, although in most cases they are needed but may not be needed. So that subject we are examining. So that is obtaining history and physical examination, but as long as you are working for an institute or in a hospital setting, among these particulars, name, age, gender, address will be provided by the institution authority itself. But if you are in a clinic of your own, then it is your responsibility to do that. Either you have some assistant or you have an office where these patient particulars are gathered, or you have to do it by yourself. Okay. On the prescription pad you have to note it by yourself: name, age, gender, occupation and address. Now what is the importance of name? Importance of name is just identity. Obviously the medical issue of a subject, whatever medical issue, whatever physical issue, cannot be related to the name. It is not that it will depend on the name. So, name is just for the identity, okay. But age, gender are two things which can relate to medical issues. These things are prevalent in old age, these things are prevalent in children, this is a more of a childhood disease, okay. Age can be related, gender can be related, there are diseases which are carried in the females, but the males suffer. One classical example is hemophilia, we will discuss in the hematology classes. Hemophilia, at least this is a very classical example, that hemophilia is carried in the females, but the males suffer from it. There are hereditary diseases which are depends on whether the subject depends on the subject's gender. So, gender of the subject has some relation to physical issues. It may have relation. So, age and gender, but name obviously does not have. Name is only for identity. Age and gender is obviously for identity, but it may have related to medical issues as well. Does address have any relation to medical issues? Can have. How? AQI. Okay. Somebody is coming from lives in a very congested area in a polluted environment. Somebody is living in a slum, unhygienic areas where even proper water supply, proper sanitary conditions are not there. Diseases may be related to that. So, address is important, but obviously address particulars of address are not important, that is for administrative purposes. Like in cities and towns we have house numbers, obviously the house number is not related to the medical issue of the subject, but as a whole where the subject is living, where the subject is coming from, that is important in establishing some medical issues. Sometimes, often it is related, at least sometimes it is related. Is occupation related? Yes. Occupational, there are something called occupational hazards which you have to study in medical science. Occupational hazards will be studied as a topic in community medicine. Community medicine classes you are having from the first year itself, at least one lecture class each week, every week, and some field visits. So, community medicine you will come to know of occupational hazards. So, different occupations, respiratory diseases and all, people working in coal mines and all. So, occupation may have a relation to the physical issues. Okay. So, name, age, gender, address, occupation, these things we have to note. These are called the patient particulars. So, history, obtaining history starts with patient particulars. Now, as long you are working at an institution, probably not the occupation, but name, age, gender, at least these three, and short address, whatever, but you have to gather more information. If just the address is given, if that part of the address particulars just are relate to administrative purposes, then you have to take history on your own, that are you living in a slum area, rural area, slum area, a congested city, town, where are you coming from? So, these things are important. So, patient particulars include name, age, sex or gender, and occupation, address and occupation. This is followed by something called chief complaint. So, if this is point number 1, this is point number 2. Chief complaints. Chief complaints means, yes. Weight and height. Yes, height and weight are measured. They are usually done as a part of the physical examination. Okay. So, during history taking, we can, as patient particulars, we can note the height and the weight, but it is a part of the general physical examination as well. Okay. So, height, weight we can include here, whatever he told, among patient particulars, but that is actually a part of the examination itself. So chief complaints are something, the issues, the symptoms of the spoken of by the patient. Now why you are calling it chief complaints? Now you will see as medical professionals, some people are coming and they are telling about, vaguely they are going on speaking about 10-15 issues. But probably as by your experience you have to gather from them which is the, that issue, which issue is that person has come for at this point of time. But some, there will be subjects who will be speaking of, yes, I am having fever, this is my issue, fever for the last 3 days, that is my primary issue right now. I have a lot of issues. I am suffering from increased blood pressure, I am suffering from increased blood glucose, I have diabetes, I have this and this, but primarily in the, say in this month of December, in this month of January, I have caught a bad cold and I am suffering from fever and headache for the past 3 days, past 4 days like this. So at that point of time, those are the chief complaints. They may be, example, say fever and headache for 3 days, or fever and body ache, generalized, that we call generalized body ache for 3 days, or all of these. So there may be associated issues also, but maybe a few will pick up as chief complaints and we write them as chief complaints. Okay. So sometimes, although these are not universal, these are not any universal abbreviations, but in prescriptions we write this as CC, and in the medical world it is accepted. CC means chief complaint, C/C. Okay, so patient particulars, after noting patient particulars, we will probably try to, or we will try to note the chief complaints. But it will depend on the subject, how the subject is communicating with you, that some subjects may be there, or some individuals may be there who will just pick out various things at a time, but you have to pick up by your experience that what should be the issues for which I will be treating right now. Those are, and obviously the subject may also have some chronic issues which are persisting over a period of time. The subject has increased blood pressure for which is being treated, which he or she is being treated. The subject has increased blood glucose, diabetes, other diseases. But for that point of time, the chief complaints will be the issues for that particular issues for which the subject has come to you right then. Okay. So those are the chief complaints. The chief complaints, along with chief complaints, after that we note something called, for learning purpose you can point it as number 3, history of present illness. That is not only in elaboration of the chief complaints, so fever, for how many days was it associated with something or not, did it come down, is it coming down with medicines, are you taking some medicines, over the counter medicines, yes, duration, or it is persisting in spite of medicines. If you have taken medicines, say for I am suffering, somebody is having fever, so he or she has taken over the counter medicines, so is the fever going away after taking medicines within 30 minutes to 1 hour, or even in spite of taking medicines the fever is tending to persist for long hours, again the subject has, all these details, whatever the subject complains of, and you try to gather by your own experience what may be the details of that. So not only the chief complaints, you will also note about the associated complaints. Are you having anything else? So maybe sometimes the individuals will not speak out everything by their own. So in this, along with fever, are you having headache? Are you having body ache? Are you being able to take food properly? Okay. Or is it being hampered? Do you have, has your taste sensation is persisting or not? Or it has decreased after you are suffering from this fever. In viral illnesses, these taste sensations, smell sensations go away. Okay. In illnesses caused due to this. So all this you will include, you will just elaboration of chief complaints and associate complaints in the history of present illness. That we will write as history of present illness. Okay. History of present illness, after writing this you will note the history of past illness, and this is again a very broad area. This will include the subject's medical history as well as the any surgical history, that have you suffered from any prolonged illness in the past for which you have to hospitalize for a large period, any prolonged illness or anything which you can remember that which caused a very considerably significant issue. Have you had any surgical intervention in the past? Okay, somebody tells yes, yes sir, or yes madam, I had.
Some diseases will not be include the patient's like family history.
Okay, I am coming to that. Let me complete. Okay. So history of past illnesses. So we'll just try to gather. Okay, have you had any surgical intervention? So yes sir. Probably the subject is coming with fever and headache, some respiratory illness. Probably by somebody will not mention by himself or herself. Okay, I had cholecystectomy means the gallbladder is operated on gallbladder. So that history will he or she will probably not give by, but it is your responsibility to note it down. Okay, this person has been operated for this. Okay, he or she had appendicectomy. The appendix has been removed. Okay, or say you are examining a lady, so some history. So examining a lady of the reproductive age group. Okay, so how many children do you have? These are among obstetric history, but some things we are noting as history of past illnesses. How many? Were they born by normal vaginal delivery or by cesarean? These are all parts of obstetric history. Obstetric history will somewhat differ. They have some different aspects from this general history, but these things you try to note. As medical professionals, you try to note not everything is related to the present issue, but more or less you try to note different things, so that some things may help you in diagnosis. Okay, so not all things will be relevant, and that will come by experience, but some things you may get some relevance from the past history. Like somebody is having fever and cough, whether that person has suffered from tuberculosis in the recent past or not, that may be relevant. Maybe tuberculosis is recurring, maybe he or she did not complete the course. So there, as you gather knowledge from this medical field, as you as your experience increases, you will yourself understand that which history of past history is relevant to this in this present time when you are examining the subject. So like that you try to gather the history, past medical and surgical histories, especially history of prolonged illnesses should be noted in history of past illness. Okay. So whenever you learn something, I always advise as beginners, you learn, so point wise you try to note how you are learning this history, obtaining history for the first time. You just try to gather the points that these things, as you go on, your experience goes on, increases. When you will become medical professionals, you will yourself find out how to gather these notes. These are no hard and fast rule that you have to write like this, point wise 1, 2, 3, 4. No, in the prescription, and you will not get so much time as medical professionals. But whatever relevant is needed, you have to note, and that will come by experience. But when you are learning, you go point wise. Okay. So except history of after history of past illness, you have to note some. So family history is, this mainly relates to the primarily relates to the non-communicable diseases like respiratory illnesses. Okay, respiratory illnesses, like they are communicable diseases, like droplets are floating through the air and they can be communicated from. So a person who is coughing vigorously, although this concept of mask was generally very largely introduced during COVID times, but any person who has respiratory illnesses should use a mask, ideally should use a mask. Okay, so because they are communicable diseases, but non-communicable diseases like say diabetes, hypertension, okay, these different hereditary diseases, they are passed on from one generation to another, but they are non-communicable. Obviously, diabetes cannot be passed through air or water through one person to another. Okay, so hypertension, increased blood pressure. So these, whether someone has your family, and now somebody may not have or probably won't have a knowledge of what had happened three or four generations before, but it may be related. It actually may be related. Somebody's great-grandfather's great-grandfather had diabetes, but diabetes was not established. Somebody had led a healthy lifestyle, so it was not established in the further generations. But at least 1-2 generations they should be knowing. So if you have to extract that information from the subject, if he or she does not speak it out by itself. That is what is about family history, what she was just speaking of. Okay. Personal history relates to, it can relate to many things, hygiene and all, but personal history mainly we take the history of addiction history, whether the person is a chronic smoker or active smoker for say past few days, 1 month, chronic smoker. The difference between acute and chronic in from the medical point of view is chronic is acute is sudden onset, subacute is still lesser, but chronic is in for most diseases it is greater than 3 months, some diseases it is lesser, but that is chronic persisting for a longer period of time, or acute. So whether the subject is a chronic smoker, whether addiction to alcohol, addiction to other things, all these are included in personal history, including her his or her food habits, hygiene, okay. This addiction history, all this comes under personal history. So these are few points which you can relate as you go on gathering experience, seeing patients, visiting patients. This history taking is like an art which will come to you. More you are experienced, more you will be good at it, but these are some salient points which should be noted. Okay, but chief complaints and present illness obviously you have to note, and related past illnesses along with family history and personal history. So as you go to the start your clinical interactions with the actual patients, this will, and as you become more experienced, this will be easier to you. So along with history taking, probably as medical professionals, whenever a subject comes to us, along with history taking we are going for the physical examination also. Okay. So along with, we are doing the general physical examination as medical, and along with that we are noting the history, we are asking things and noting it down. So this has to be more or less done simultaneously. Now whatever we have spoken of till now, we have assumed, more or less assumed, that this is an adult person who is speaking to us. Now there may be conditions, you are seeing a child. So small children always can't give this information of their own, especially if they are very young children, infants and all. So that history will have to be obtained from the child's guardian, most probably the mother. If unfortunately mother is not there, mother has passed away or something, the child's guardian who will bring the child to you. So you have to obtain history from that person. If some person has some psychological issue, adult person has some psychological issue, cannot speak it out by himself, then relatives will be needed, okay, for obtaining that history. So those are conditions where you cannot gather the history from the subject himself or herself, but for the sake of discussion we are assuming that we are taking the history from the subject himself, but there will be these conditions. In very young children, the children cannot themselves obtain the history, and these points are just some gross ideas. Obviously you won't be asking, say, the mother of a very young child whether your child is a smoker. That is very foolish to ask those things. So not that all points will be applicable to in every case, but that depends on you. That means whatever is relevant you will ask. Sorry. For general physical examination, what I should first tell is that physical examination is from head to toe in general, head to toe. But for the sake of learning as beginners, we learn it as some points. Physical examination will go from head to toe. So, but we have to note some salient points. Whenever we meet a subject, the first point to note is, even without touching him or her, even without touching the subject, Built and nutrition. So somebody is coming to the outpatients department, you are seeing that person for the first time, very lean and thin, very obese. Okay, these things can be noted. Whatever is visible from outside, those things can be noted at once at the first visit. So build and nutrition. So whether the subject is very obese or subject is very lean and thin, okay, and that may be related, these things may be related to physical issues. Okay. Now using a measuring tape and measuring the arm circumference, the chest, all these things again will be discussed in community medicine. So we measure the arm circumference, forearm circumference, chest circumference, waist circumference. So and this relates whether the subject is suffering from malnutrition. All these things relate to the build and nutrition. So this is the first point we have to note as a part of general physical examination, and whatever he was telling, height and weight comes under that. So to note the height and weight, we need instruments, okay, weighing machine, height and weight comes under that, build and nutrition. Okay. So next we can talk of 4 points together, and these are also called the vitals, vital signs: pulse, blood pressure, respiratory rate, and these are also called the vital signs. So among these, pulse and blood pressure have already been discussed in separate classes, but this is actually part of general physical examination as well as under the cardiovascular system examination. Respiratory rate is just counting the respiratory rate by looking at the subject. Probably it is better or it is necessary, actually it is necessary to expose the upper part of the body, thorax and the abdomen, for respiratory rate, but as a part of general physical examination, we usually do it with the clothing on, but we count the respiratory rate. Now one thing to note is, when we are counting the respiratory rate, if the subject is aware that the respiratory rate is being counted, then maybe the subject may become anxious and all, and the respiratory rate changes, it increases. So what we have to do during counting the respiratory rate, one rule is that you keep your hand on the radial pulse and pretend as if you are counting the pulse rate. But what you are actually noting, you have already noted the pulse rate, but what you are actually noting at that time is the respiratory rate. So for counting the respiratory rate, don't let the subject know that you are actually counting the respiratory rate. This is one rule. For noting the temperature, we will just keep one hand, we will show it on the subject's forehead or on the back of the neck, and for noting it, just for measuring it, to get a numerical idea, we have to use the clinical thermometer. That is how we note the clinically we note temperature. So pulse, blood pressure, respiratory rate and temperature, these are points to note under general physical examination, and when you will become medical professionals in the working in inpatients department, you will this will be a medical directive to the nursing personnel that you note for pulse, blood pressure, respiratory rate, temperature. These are also called vital signs. For some patients, they may be required even 2 hourly also. So you note them 2 hourly, and when as you are the consultant, when you are coming back for the rounds in the evening, you again note what were the vital signs 2 hourly. If there is any gross abnormality, then you report it to me at that point of time. Otherwise, when I will come back for the rounds, I will note it. You go on noting it 2 hourly. Or the general norm is noting these things, at least these 4 things 4 hourly. Okay? Pulse, blood pressure, respiratory rate, temperature. Next comes points to note. Pallor is paleness, usually pallor is paleness, usually related to anemia, anemic condition. Anemia is, we will discuss anemia in the theoretical classes. Anemia is reduction in RBCs or hemoglobin or both. Okay. So, pallor is usually related to anemia, but it may be related, it may be unrelated to anemia also. So, under general physical examination, we do not call this as anemia, we call this as pallor. Sometimes it is unrelated to anemia. You have to note for paleness, and there are sites for it. There are some common sites for it. Okay. So, those common sites will be coming, we will be doing this examination hands on. Cyanosis is bluish discoloration of the skin or mucous membrane. When reduced hemoglobin goes below, when we will be discussing the theory, we will know about the definitions. When reduced hemoglobin goes below 5 gram %. Gram % means 5 gram per DL or 5 gram per 100 ml, 5 gram %. Jaundice, another name for jaundice is icterus. So, you do not have to write these things actually, all these in the textbooks. Any physiology practical textbook you follow, you will get these things. Jaundice is, another name is icterus. So, jaundice is yellowish discoloration of the skin or mucous membrane when serum bilirubin goes above 2 milligram % or 2 milligram per DL. Hemoglobin is in gram per DL. Bilirubin, serum bilirubin is measured in milligram per DL. Serum bilirubin going above 2 milligram per DL, and due to that yellowish discoloration of skin or mucous membrane, that is jaundice. Clubbing is, by definition, it is loss of onychodermal angle. Now, onycho relates to nails, dermis is for skin. So, you see your own nails, the dorsal aspect of the hands, own nails, where the nail is meeting the skin nail bed, there is an angle, it forms an angle. So, when this becomes, if we just very grossly speaking, if this becomes straight, if that angle is lost, that is called clubbing. So, to see it, we have, there are procedure which we will just show, we will do, and we will have to do hands on. Edema is swelling, that is edema is due to the fluid of that is the disease, but it is due to fluid accumulation in tissue spaces or interstitial spaces. As we have just mentioned during the hematology blood collection, if we press the finger and try to secure blood, this capillary blood, then what more than blood, what comes out is tissue fluid, that is fluid in the tissue spaces. If this increases, there is swelling, that is called edema. And 1, 4, 5, 9, 10 points. We may add 1 point about noting about the neck veins and neck glands in general physical examination, and we will show neck veins, glands, palpable glands, which can be felt by the hand in the neck, and noting for any engrossed veins in the neck region. This is what is general physical examination. We have to cover these points. So, total 11 points. Okay. Yes. Yes, this comes neck veins and this includes yes. So, built nutrition, pulse, blood pressure, respiratory rate, temperature, pallor, cyanosis, jaundice, clubbing, edema, neck veins and neck glands. I sometimes tell this to students as like, those who are interested in football can relate. The first, this one in football, what do you have? Formations 4-3-3, 4-4-2, 4-5-1 like this. So, first point, there is 1 point like the goalkeeper. So, build and nutrition you remember separately. Then next four are vital signs. You can remember anyway, just for remembering easily, that we have to cover all these points: pulse, blood pressure, respiratory rate, temperature. Then the 5 points: pallor, cyanosis, jaundice, clubbing, edema, and lastly neck veins and leg glands. 1, 4, 5, 1. These points we have to note. Now, what I was telling, we do it from head to toe. That means there are sites of noting pallor, cyanosis, jaundice, clubbing, all these there are sites. Now, what is there? We note the tongue for pallor as well, under surface of the tongue for jaundice, okay, and tip of the tongue for cyanosis, any bluish discoloration. So, head to toe, I mean, when you will do it actually in practice, what you do, you have to make the subject comfortable. Okay. Now, if you do like this according to, okay, I will see for Pallor now, so you take out your tongue, I will see your tongue. Again next, after few seconds, okay, I will have to see cyanosis, you take out your tongue. That will be uncomfortable for the subject. Again jaundice. So, actually when you become medical professionals, whenever you see the tongue, you note for everything together, whatever can be seen, even in the muscular, in the nervous system examination, whether atrophy of the tongue is there, because if the motor system there is atrophy of the muscles, then the tongue will also be atrophied. So, you do it, the nerves which are cranial nerves which are supplying the tongue, if they are not that there is an issue with that, then there will be, the tongue will be atrophied. So, you note it together. You do not ask the subject to protrude the tongue multiple times. Now I will note for Pallor, now after few seconds I will note for cyanosis. So, that is the meaning of examining head to toe. Whatever organ, whatever body part you are examining, you examine it together for all these things. But for learning purpose, for as beginners, we just keep it on our mind that these points we have to note. Actually, we do not do it like this, that now I will note Pallor, so now I ask the subject to take out the tongue. So, whenever you are examining the hands, note for everything what you require. Whenever you are examining the tongue, whenever you are examining the eyes, in the eyes we note for Pallor and jaundice both. But whenever you are examining the eyes, you note for Pallor and jaundice together. Not that I am examining for Pallor now, after say 1 minute again I will have to examine for jaundice, then the subject will be uncomfortable. Now, for general physical examination, what I have to remember is that for physical examination, which we should remember that these we have to follow, like one is the room or wherever we are examining, that should have sufficient light. It should be a well lighted area. We can't be doing a physical examination where there is no sufficient light. Not in the dark obviously, and not also if the light is insufficient. Like ideally jaundice can be seen only in proper daylight. Noting for jaundice, noting for this yellowish discoloration requires proper daylight. But in practice you will see that it does not mean that you will not examine for patients after sunset, examine the subjects after sunset. So, at least there has to be very sufficient light for physical examination. Well, now you have to make the subject comfortable, take his or her consent, not just hurry up, grab him or her by the neck and start examining. You have to make him or her comfortable. And for making the subject comfortable, one thing to note is, if in books it is written like this, if the subject is a female, you have to keep a female attendant. Okay. So, what I feel is this was written, books they are going on writing these books for quite some time, for 30-40 years these books are being written. So, this is written like this, that you keep a female attendant for a female subject, for a female patient, for a female subject. So, earlier used to happen, most doctors were males, but nowadays it is not so. So, you just modify it as that whenever the subject is of the opposite gender as that of the medical professional, an attendant has to be there who will be of the same gender as the subject. So, if you are a female medical professional, then and the subject is the male, then there has to be a male person to accompany him or her. Sometimes it may be his own relatives and all, but at least he has to be comfortable. It may be your assistant, somebody, okay, but there has to be somebody, otherwise the subject will not feel comfortable, and of course he will take his or her consent. Okay. We are to examine the subject for that is another point. Usually we do it from the right side, most of us are right handed. Some physical examinations can be done from the left side as well, and if we are left handed, sometimes we modify, but most can be done from right side, even if the clinician is left handed. Most of the human beings, most of us are right handed, but somebody may be left handed, still they can be done from the right side, and as a rule most physical examinations are done from the right side. So, these things are to be remembered for while doing the physical examination. Consent and making the subject comfortable is very important, and in an outpatients department as well, there has to be chairs and couches for a, you may require the subject to lie down and examine. So, there has to be couches, you can't just say lie down on the floor, I will examine you, or sit on the floor, I will be examining you. So, you have to, if you are in a working in a hospital setting or an institutional setting, the institution will arrange for you, otherwise you have to at least arrange for a table, you have to write the prescription, table, chair for yourself, chair for the subject, maybe 1 or 2 more chairs for the persons accompanying him. All these things, these are the requirements of a clinical setting. A couch where the subject may be required to lie on, and you are often they will be required to lie on the couch and you examine the subject in the lying position. These are the criteria, and obviously it has to be well lighted for physical examination. 4 more words which I will just tell you right away here itself. So, these things are parts of these 4 terms we need to remember while doing physical examination: inspection, palpation, percussion and auscultation. Inspection is that part of the physical examination where you are not, as medical professionals, we are not touching the subject. The word palpation means to feel. So, palpation, whether when we are palpating, that means we are feeling. So, we are touching the subject and feeling him or her, but inspection just means just looking at and gathering, like there is an obvious, as soon as the subject enters along with build and nutrition, we are noting the build and nutrition, height, weight, etc. We are measuring the arm circumference and all, but also what we are doing is, if there is an obvious, say obvious scar mark on the face, we note it down, and we also ask what is it for. Is it because of a surgical intervention or anything else, or if there is a small scar mark, is it by birth? So, obvious things we note, so that is by inspection. We do not even need to touch the subject. Palpation is feeling, percussion is one particular type of touch. Percussion is also called, the meaning of percussion is tap. We will require this while examining the respiratory system, abdominal systems, and we will show it how to do it. We will learn how to do it, percussion. And auscultation is that part of the physical examination which is done with the help of the stethoscope. So, these 4 terms, that inspection, palpation, percussion and auscultation, you will note it in the systemic examinations. In every systemic examination, mainly percussion is a part of respiratory system and this abdominal system examinations, percussion. So, by tapping the relevant parts of the body. Okay. So, just from the exam point of view, if you are asked that inspect the subject or inspect the chest and tell me your findings, if the examiner asks you, then during this MBBS or any curriculum, MBBS further medical curriculum, whenever you are told that you are to inspect and tell the findings, then you are not allowed to touch the subject. Whatever findings are there, just by looking at the subject, that relevant body part or the as a whole, so that is just by inspection, whatever you can find on inspection. When you are told inspect the chest and tell me the findings in the exam, this is from the exam point of view. When you are told you are not allowed to touch, okay, or you are not allowed to use the stethoscope, just by inspection. That is the significance of these 4 terms: inspection, palpation, percussion, auscultation. So, see, physical examination, as I told, should be, the rule is to do it from the right side mostly, but just for showing I am on his left side, okay, so that you can watch, but usually we do it, we are placed to the right of the subject, okay, and this is by as per requirement. We may be sitting, the subject may be sitting, the subject may be lying on the couch, we may be examining by standing by the side of the couch, whatever, we usually do it from the right side. Sometimes we modify according to the needs, but go on the left side. So, pulse, blood pressure classes have already been taken, we will practice it again today. Respiratory rate, what I told is, keep your hand on the, just pretend as if we are counting the pulse, but just look at and count the respiratory rate. Ideally, it is to expose the whole of the chest and the abdomen to count the respiratory rate, but as a part of general physical examination we do it from over the closings. But it is difficult to do, especially in winter. If there are a lot of layers of clothing put around, it is difficult to do without exposing, but we count the respiratory rate. Where the important point is, keep your hand on the pulse and pretend as if we are counting the pulse rate, and this is to be done for 1 whole minute, as we have done in arterial pulse, 1 whole minute, not that 15 seconds and we write whatever is required. Okay. So, when we will become medical professionals, we will be in a hurry, right? Why? More patients means more earnings. So, that is the aim. So, that is the aim of becoming a doctor, right? Earning more. Okay, jokes apart, but these things should be done for 1 minute, has to be done. Okay, sometimes when we are very experienced, we do for 30 seconds and multiply it by 2, but ideally should be done for counting the pulse rate and the respiratory rate. Well, it requires 10-15 minutes. But unfortunately, in this country, huge population, shortage of doctors and all, everything gets messed up, but actually ideally we should count the pulse rate for 1 minute. You have to measure the delay and equality of pulse. It requires more time to examine the pulse itself. So, respiratory rate we have to count for 1 minute. So, if it was such that we can count for 5 seconds and multiply it for 12, but that does not occur like this. So, everything has a rhythm, except in the respiratory system we will run respiratory along with respiratory rate to note the rhythm. So, it is not possible to know the rhythm about rhythm of respiration within 5 seconds. So, actually we should devote some time for it. It is ideally 1 minute for both pulse rate and respiratory rate. Temperature we note it like this, with the back of the hand we keep the subject on the subject's forehead, maybe on the nape of the neck, on the back of the neck, and clinically we do it with a thermometer. Just take off your spectacles. Okay. For Pallor, what we do, there are some common sites, like you ask the subject to just show the hands, palm of the hands, the nail beds, and note whether they are pale or there is the normal reddish tinge. And for the eyes, what we do, how we note Pallor, we have to see both eyes, and how, just look up, just downward, see. Obviously, what mistake did he make? This is not actually his mistake, it is my mistake that I did not instruct him properly. A good part of clinical examination is about communicating well. Okay. What did he do? As soon as I asked him to look downward, okay, your subjects will be laymen, okay, mostly they will be laymen, they will be not from the medical field. So, what did he do? He just put his head down. So, looking downwards means keeping the head straight, but just looking downward with the eyes. So, that is not his mistake actually, that is not your subject's mistake, that is the mistake. You have to instruct him or her properly, so that you get your job done. Okay. So, look straight and just look downward. So, when you do this, you just pull up the pull up the eye, so that the upper palpebral conjunctiva, and due to this factor I am standing, he is sitting, then I have to move myself down and note the upper bulbar conjunctiva. For jaundice, yellowish discoloration is obviously if the jaundice has advanced to a great extent, say the bilirubin levels have gone up to 10 milligram percent, then obviously the whole of the body skin will be, you get that yellowish tinge, or it will. But in initial stages, the most commonly picked up even in the initial stages is at the upper bulbar conjunctiva, in the under surface of the tongue. So, just protrude your tongue, okay, just protrude your tongue and reverse it, protrude your tongue first, okay, roll it, reverse it. So, under surface of the tongue we note for jaundice, and the tongue, whole of the tongue, the tip of the tongue we note for bluish discoloration, that is cyanosis, and cyanosis is also noted near the nail beds. This bluish discoloration also noted near the nail beds. So, these are the sites. So, sites you will get in your books, and in the initial stages you have to practice a lot. So, how to practice? Whatever I keep, what I keep on telling is that according to the medical council, medical education is strictly residential. Okay. So, one purpose of that is that, this is that you have to practice this clinical examination and all, but due to various practical issues, that many people are not living in hostels, they are living outside, but you have to practice. Clinical examination, we devote 1 or 2 hours for a particular topic, maybe 2 classes, 4 hours, it is not sufficient. The more you practice, any hands-on training, more you practice, more you will get experienced. And remember, you will become medical professionals. You will become professionals. This is a professional course. If you can't, if you don't have that knowledge, the harm is your own. Okay. So whenever you become, after you become a professional, nobody is there to teach you. Okay. So you have to learn. Anyhow, you have to learn. See, I am telling it on record. You are not admitted in a premier institute. In a premier institute, maybe they are having more faculties. They have, for 5-10 students, there is one faculty who can devote. But in institutes like this, say, so 50 students, one faculty, for at maximum for 50 students, 2 faculties, like this. So 50, 100, 100. So, but you have to learn. When you become professionals, you have to learn and apply yourself. In this medical field, you have to apply yourself. There nobody will see where you have passed from, whatever, but you have to learn. So at least for the clinical part, you can do it on your own, and whatever I advise is that from the first day clinical examination, simple things will keep with you, because as professionals you have to keep with you after say 4-5 years. So institution is bound to, as you are admitted in this institution, you have enrolled in a medical institute, the institution is bound to supply you instruments. But whatever you will require after 4-5 years, my suggestion is that you stethoscope, a sphygmomanometer, simple things like a measuring tape, a torch, you keep this with yourself. Even during the examination, you will need them. How I will tell you, say in a particular room, 5 or 6 candidates are appearing for the exam. During the exam, I am telling about this exam setting. So some examiner, there will be 2 or 3 examiners over there, 5-6 people, 2 for one examiner, another 2 for another examiner. So sometimes there are simple clinical examinations with the torch. So they are asking you to show. So a torch on the eye, there are clinical examinations which you learn, which can be done with the torch, and they are very simple ones. Okay. Or a measuring tape is required for measuring the arm circumference. Okay. So built-in nutrition, we don't have a tape right here right now, we should have, but we don't have. Just simple measuring the arm circumference with a measuring tape in the middle of the arm. So these things, so the examiner asks you, okay, do this clinical, show this clinical examination, and you require the torch. Now say there are 2 torches in that room, but in some other tray, and the torch is right there, not available, right at that point of time. Now what will happen, the examiner will say, okay, we don't have a torch over here, you passes on to some other question, which may be a relatively difficult one. So I will suggest, and I am saying it on record, we means the institute cannot compel you to have those things, but I will suggest for your own good, simple things you keep with you, and you carry to the classes as well for better learning. See, we have 4 of them over here, 4 sphygmomanometers over here. So if you have your own, just label it so that it does not get mixed up with others. Label it. If you have your own instruments, it's better, but nobody is compelling you, obviously. But if you have this stethoscope, sphygmomanometer, torch, a measuring tape, like you have a pen and a notebook, as a medical student, if you have this, it will help you. It will help, you will help yourselves. But there is no compulsion. Okay. As much as possible, the institute is bound to supply you. Here, in our department, there are 4 these things for learning. These 4 have came newly. This just supplied last week, I think, for this clinical class purposes only. But if you have your own, it will help you. So, and these things, if you have, you can practice at home as well. Okay, you can practice at home. Many things will not require instruments, they can obviously be practiced. You will make groups or your own. Unless you practice in clinical examination, you will not feel confident. During the exam, simple things, mistakes are being made, because these are very simple things. To ask the subject just to look up or look down and note for some clinical findings. These are relatively simple things, there is nothing tough over here. But still, during the exam, after you cover these 3 subjects in 1 year, there will be so much to perform during the exam. that without practice at that moment you will forget things and make mistakes, right. So, please practice by yourself, making just in hostels or in groups, in the canteen, wherever, just like just passing some time, you devote some time to these things. The more you practice, the more your experience will be more and more you will remember, and it will get, before visiting the wards, the purpose is in the first phase, before visiting the wards and actually examining the patients, at least basic parts of this physical examination you are well acquainted with, okay, as medical students. So, pallor, cyanosis and jaundice, these are the areas to note. Clubbing is loss of onychodermal angle, that is the how you see. As beginners, I will suggest both hands, you just keep like this. Whatever you remember, your subjects when you are examining your subjects or patients, they are laymen, so you have to instruct how they are to keep. So, keep both hands like this and see from the side, it will be possible to note whether this angle is persistent or lost. Now, in the first year, okay, in the first year, what will happen? Probably most of us, we are not suffering from disease, we are all normal. So, we are just concentrating on the procedure, okay, we are concentrating, just learn how to do it. So, probably most findings will be normal, okay, unless your friends are your volunteers, your colleagues are your volunteers, unless someone has got a very bad cold and coughing, you can't get positive finding, means you can't get findings during examining the respiratory system, but you learn the procedure. If the procedure is wrong, in the first phase we concentrate, as the examiners also concentrate from the examination point of view, they will show, the examiners will be examining whether you know the procedure rightly or not. Findings mostly you won't get, at least in the first year, when your own friends, own colleagues are the volunteers for the clinical examination. So, the how to note for clubbing is for looking from the sides. Another way to note is just asking the subjects to make the hands like this. See, if they make the hands, they oppose the hands like this, if there is this angle, if the angle is persistent, there will be diamond like gap, diamond shaped gap in the middle, but if this angle has been obliterated, then that gap will reduce, that gap will no more be diamond shape. But as beginners, it is better to note like this, and from the side. It won't be possible to note this obliteration of the angle if you see it from the front, so you note it from the side. Simple things, but still you practice. What happens? Mistakes, simple mistakes, these mistakes, if you don't practice, sometimes in a hurry, what you do during the exam, so you note it like this. So, you cannot note this obliteration from angle from the front, you have to note it from the sides, then only you can see it properly. If there is actually any obliteration in this first year, first phase, mostly you will find the findings will be normal, but your procedure has to be correct. Okay. So, next is neck veins and leg veins. Just look for engorged neck veins. There are due to different causes, whether engorged neck veins, there will be bluish veins visible on the skin, and just take the mask off for 1 minute. And for neck glands, you do this like this from the, usually from the back. Just neck glands over in various respiratory illnesses, especially in upper respiratory tract illnesses. These glands we find engorged. Again, we do the procedure correctly, learn the procedure correctly in the first this first year, and when you actually go to the wards, you will find this findings you will get. Okay. One thing is left, that is edema. Usually there are edema at different sites, but usually look for pedal edema. Just come over here on this couch. Okay. Now again, in a hurry, don't just do it for 2 seconds, then the findings will be wrong. So as we probably he is we won't get any findings anyway, normal, but for getting the findings, for obtaining the findings, the rule is to do it for 20 seconds and leave it, and seeing whether this depression which is made comes back to normal. Okay. If there is interstitial fluid tissue spaces, then you will see like that, so that whether it is coming back to normal within a short time. So this is noting for pedal edema, we can note for sacral edema also, but just as in the beginning you note for at least for pedal edema. Okay, thank you. Just so edema, we look for pedal edema like this, and whatever can be done bilaterally, you see both the eyes. What cannot be done, what is not possible bilaterally, what does not exist is another thing. Obviously, human beings have one tongue only, so examination of the tongue cannot be bilateral. Okay, examination of the jaw, examination of the nose cannot be bilateral. Still, you have to examine, wherever we have to examine the nose, we have to examine both nostrils, not one nostril. During sense of learning, we learn the nervous system examination, testing for smell sensation or some person with some object which is which will this influence the olfactory system, will smell it. You have to smell it with both the nostrils. Okay, we have to examine as examiners, we have to do it. Clinical examiners with both the nostrils. One nostril has to be blocked, the other nostril has to be examined, then another has to be blocked. Whatever is possible bilaterally, it has to be done bilaterally, otherwise it is a discredit. You are getting your findings wrong actually. So whatever is possible bilaterally at once, you do it with your 2 hands, like examining the eyes, examining for pedal edema, and what is not possible together, you have to do it separately for both sides of the body. But the tongue examination, as tongue is one, so that is not a area for bilateral examination, that is only a single time. But most things have to be done bilaterally. So now how many are there? Maybe 20-25 people. So just make groups of 5 and just practice it yourself. Pulse, blood pressure has already been done. If somebody has not attended those classes or had not got admitted, we will help you out, but just make use of this whatever time is remaining, 20-25 minutes, and just practice. But I again repeat that 1-2 hours classes or maximum 2 classes, 4 hours of subjects classes are not sufficient for learning the physical examination, clinical examination very thoroughly. So you have to practice it by your own, like you have to study theoretical aspects by your own. Obviously, only attending one class on one topic you cannot remember everything, or you cannot gather it everything and just sit for the exam. Like clinical examination, you have to practice on your own, otherwise it will be difficult for you. So whatever time is left now, just practice among yourself. You don't have your roll numbers yet, so just you have to make random groups. If someone has not attended classes on pulse and blood pressure, just who have attended help you out, and I am also there. So one thing is you have to tie the cuff properly. Tying the cuff, that is, even as beginners you have to learn how to tie the cuff. So ideally you have to expose this part, okay, because blood pressure theory, have you been taught about blood pressure in the theoretical classes till now? Yes. Cardiovascular classes going on? Yes, sir. So whenever we are, this is what method of measuring blood pressure, direct or indirect? Indirect. What is direct method? So yes, cannula inside the artery, so that is not practical. Every time we measure, so mostly commonly in medical field we are measuring the blood pressure. So this sphygmomanometer, whatever this mercury column, these are just instruments which have been calibrated with the mercury. So these readings are in millimeter of mercury, whatever is there. So earlier we used to have with the mercury columns itself, the mercury itself is there in those columns, but these instruments have been calibrated with the mercury, and this is in millimeter of these readings, whatever readings over here, these are in millimeter of mercury. Now what is the rule? Now what is the rule? These are all indirect. So why you are speaking? What is the we will not call it a disadvantage, but what is maybe a fallacy of indirect measurement? That is another thing. Auscultatory gap comes next. No, that is not. That is according to that is the methods we are coming to. So indirect measurement, are we getting actually higher blood pressure or lower blood pressure than direct blood pressure? Why?
Because of peripheral resistance.
Yes, because this instrument has to overcome the pressure, not over the blood vessels what are lying, subcutaneous tissue, skin, fatty tissue, and if there are 1 or 2 layers of clothing above that, so everything it will, the machine cannot differentiate what it is, what pressure it is overcoming. So it has to overcome so many. So it is actually we are getting higher than the actual, so the blood pressure. So ideally it is to be done directly, but that is not practical. So it is actually somewhat lower than whatever getting over here. So we cannot eliminate the skin and subcutaneous tissue, fatty tissue, it is cannot be eliminated, but what can be done is at least we do it on the bare hands, okay, or the bare arm, okay. So more layers of clothing means becoming the reading is becoming more fallacious, okay. So the there are 2 methods, and 2 methods are to be done one after another. So 2 methods means palpatory method and auscultatory method. In one part of the examination we use the stethoscope, but preceding it we do not use the stethoscope, but it is not that it is optional, okay. By the palpatory method we get only the systolic part of the blood pressure. By the auscultatory method we get both the systolic pressure and the diastolic pressure. Okay, and there are other, there is another reason for it, why do we do it for systolic and diastolic. Just give me one stethoscope from here. Okay. So for the palpatory method we do not use the stethoscopes. For the palpatory method we touch and feel the subject. So what we have to do in palpatory method for blood pressure, we first have to feel for the pulse. As we feel for the radial pulse with the 3 fingers, we first feel for the pulse, okay. We for help, if we have an assistant, that is better, but if we do not have an assistant, then what we will do, we ask the subject to keep the hands over this instrument, just press it tightly, okay. So what is press it like this, okay. Keep the hands over it. So the idea is to, what is the principle? After this we use this instrument, what is the principle? Obstructing or eliminating the flow of the blood through the brachial artery, okay. So what is, have you as you have done classes now, probably you know about it. Do you know about laminar flow and turbulent flow? No, so blood flow is usually, what is usual blood flow going on in the blood vessels, that is laminar blood flow, versus turbulent blood flow. When a sudden obstruction is released, then there is turbulent blood flow, and sounds are only heard in blood flow when the blood flow is turbulent. Usually there is no sound. So the principle is, we are obstructing the flow through the brachial artery and then releasing the obstruction when the blood flow is becoming turbulent. Those sounds are picked up by the stethoscope, and we are the corresponding reading is seen for noting the blood pressure. But in the palpatory method there is no that is in the palpatory method the stethoscope is not used. What we will do, we will keep our hands on the pulse. So as we will be requiring our dominant hand, mostly our right hands, in most human beings right hand is a dominant hand, the left hand is a non-dominant hand. As we will require this to see the, as we will require to note, okay, you press this, as we will require to inflate and deflate this with our dominant hand, on the radial pulse we will keep the fingers of the non-dominant hand, okay, and then take up this, we will have to inflate it. Then what happens, how up to which point should we inflate?
160.
Has somebody told like that?
Yes, sir.
So if you do it up to, you can do it up to any value, but ideally it is up to, no, it is up to where the pulse is obliterated. That is the reason for using the palpatory method. So don't make any arbitrary numbers like that. 160 is probably, as beginners you are told, because probably you are learning on your own colleagues. So the blood pressure may be above 160 also. Till the pulse is obliterated, you have to go on inflating it, and it will be obvious, it will be at once. Okay, why did I release it? Because otherwise she will feel uncomfortable. Okay, give that hand, doing it on one hand, she will feel uncomfortable for a much more period of time. So, the idea is during the palpatory method, not the idea, this is what is to be done is, again press it, okay. We are noting her pulse, okay, and we are inflating it up to where the pulse is obliterated. So, after, see, already after 110, we are no more feeling the pulse, okay, and just take it 20 above, where 20 or 30 above, where the pulse is no more found, okay, and then gradually bring it down. Wherever the pulse rate, this feeling of the pulse will come back, that is the systolic blood pressure, right. So, the point is okay. Okay, you come. So, the first point is up to 100. Why did I do it up to 130 or 40? Because it was obliterated as 120. So, actually no need to do it up to 160 in this subject, because there is something called the auscultatory gap also, but 100, you know of it, I think, as you have done the theoretical classes, but 100, if you are, the pulse is no more felt at 110, it is sufficient to raise it up to 130 or maximum 140, not above that. So, again when the pulse is felt again, usually it is at that point where this feeling was not there. When it is coming back, when that pulse, again you note the pulse, that is the point of systolic, that is the systolic pulse rate. Now, what happens is during auscultation, when we hear it in the stethoscope, what happens is that again ideally the arm should be there. Just hold it, okay. So, ideally the arm should be bare. Now, and again we have to do the palpatory method, okay. So, up to where the pulse gets obliterated, or the pulse is not felt anymore, okay. So, we have to put the stethoscope for the auscultatory method, okay. First we do the palpatory method again. So, I am feeling her pulse. So, to feel the pulse, again it is not actually the right one. How to feel for the pulse? Yes, this is what more is to be done. We are just doing it in a short time, semi-flex and semi-pronate. If the person is very obese, or then it will be difficult. So, the easiest way to find is by first semi-flexing and semi-pronating. Pronation is this, supination is the one individual is lying on a horizontal surface with the back on the surface and the front upwards towards the ceiling or above, then it is supination, and pronation is this. So, semi-flexing and semi-pronating we are noting for the pulse, then we are inflating the cuff, and when the pulse gets obliterated we will note for this, and it should be done more slowly. So, now the pulse has got obliterated, we just, as it is at 120, we just go up to 150 and then gradually release it, and the hands are to be there on the pulse, the other hand. So, it has come back at say between 110 and 120. Just remember, in this graduated sphygmomanometer, the readings are at a spacing of 2, minimum spacing is 2. After 110 it is 112, then 114, 116, 118. So, although blood pressure obviously can be theoretically can be odd numbers, but with these instruments you have to speak of even numbers, okay, because the graduations are like that. You can speak of 114 or 116, but not 115, as graduations are not there, okay. So, the pulse, this pulse was again felt at 110 or 120. So, the systolic blood pressure is 120, but the reading somewhat differs in auscultation. It may be 10, 20 above, 10 to 20 above what was noted in palpatory method. To note the blood pressure by auscultatory method, we have to again keep the stethoscope. Now with the stethoscope we have to hear sounds, and for hearing the sounds we have to note the stethoscope over the, put the stethoscope over the artery, that brachial artery. So in the elbow, this area, as you are going on with superior extremity, when we are just flexing the forearm, this area which is formed, this is called the cubital fossa or the antecubital fossa. So there is the arrangement of the vein, nerve and the artery is medial to the vein and the nerve. Cephalic vein, sorry, not nerve, the tendon of the biceps brachii and the brachial artery. So if you just semi-flex the subject's forearm, so just the hard structure which is found is the, you can see it on your own hands, it is, or own elbow. The hard structure is the tendon of the biceps muscle. Okay. So medial to that is the brachial artery. So by feeling the just semi-flexing and by feeling the tendon of the biceps brachii fast, you have to note where the biceps, the brachial artery pulsation is felt. After that you have to put the stethoscope over there, because it is no use putting the stethoscope at an area where the biceps artery, brachial artery is not there. Okay. So you have to put over the brachial artery, then you start inflating. And up to how much will inflate? Again, whatever the systolic pulse was noted in the palpatory method, 20, 30 above that. Okay. So palpatory method we noted 120, so I am doing it up to 150. So there is no rule that it has to be done up to 160 or 200 like that. That is for, because we are estimating that on our we are all normal, so it will be within 160. But there is no, cannot be hard and fast rule among that, because in a very person with a very increased blood pressure, it may be even be 200, 220. So we do it up to 150, we gradually lower it. The appearance of the sound is the systolic pressure, and now the sound has gone off about 90, so that is the diastolic pressure. So this is the, wherever there is the appearance of the sound, that is the systolic pressure.
And the disappearance
Disappearance is the diastolic pressure. Okay, you are comfortable? Okay, just sit. So disappearance, but theoretically we speak of a term called muffling as well. So some texts are writing just before disappearance the sounds are getting, that phase is feeling of the sound is called muffling. That muffling phase is the diastolic, and the disappearance phase they are not considering, muffling is diastolic. So some authors are writing muffling as diastolic, some authors are writing disappearance as diastolic. Just as beginners, you just forget the confusion, you take the disappearance as diastolic, and some authors are even writing blood pressure like this, 120 say by 80 by 70 or by 74 or 116, it will not be just a multiple of 10 always, 116 by 84 by 78. Why? That 84 is muffling and 78 is disappearance, but to avoid these complications, as beginners you take this, appearance is systolic, disappearance is diastolic. Now these are days of MCQs. Okay, in MCQs you will sometimes there are dubious MCQs which in my opinion should not be set. If what is the marking point of diastolic blood pressure? If both muffling and disappearance are there, you go for disappearance, but usually there will be one of these. So if there is muffling, you go for muffling. If there is disappearance, you go for disappearance. But with systolic, there is no ambiguity, it is appearance of the sound. So the principle is the obliteration of the blood flow through that, it can be done on other arteries as well, through the artery, and when the blood flow is again established, as this is now turbulent blood flow, sounds will appear, and as turbulent goes on to laminar, sounds will gradually disappear. So either muffling or disappearance, to avoid confusion, at least during as beginners you go for disappearance. And if usually if it is if the MCQ is that means proper one, then for disappearance it will be either given muffling or it will be given disappearance as options. But if you find both options, you have nothing to do, and you have to choose one, then you choose disappearance. Okay. There are MCQs are being said these days where it is told that you can mark two options, then you mark both. Okay. Then both marking, and the days are coming when MCQs will mostly be, after this MCQs days are coming when there will be computer based tests only. So that the software will allow you to mark one or more options, and there will be, I think days are coming where you will be allowed, if you think more than two options, various institutes are taking their administering their entrance exams like that, that it is up to the candidate to choose. So if somebody chooses in MCQs, say there are 5 options, it is up to the candidate to choose, they can choose 5 also. But if they choose even one single wrong option, then you get discredit for that. The candidate is discredited for that. So you have to choose the correct options only. Maybe if there actually 3 options in that, 3 options in one MCQ are correct, then if you choose 2 of them, maybe there will be part marking, but choosing one wrong option will lead to discredit, full discredit. So days are coming when it will be computer based. So as long as you are allowed to choose more than one, and MCQs are set like that, muffling, disappearance, this is just one example, then you can choose both. But if you are to choose one but both are given, that is setting an ambiguous question. That should not be like that, then you choose